Thanks for joining us to help choose home when care is needed, a podcast all about the benefits and value of receiving care in a place that you likely feel most comfortable, your own home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Each episode, I'll be talking with a guest who will help us in our quest to educate about healthcare at home. So let's get started on today's episode number 5. Our guest today is Dr. Warren Hebert. Dr. Hebert is the CEO of the Homecare Association of Louisiana and an assistant professor of nursing at Loyola University. His doctorate is in nursing practice, and he's also a Robert Wood Johnson Fellow, Executive Nurse Fellow alumni, and someone that has been in home care a long time and has a perspective that I think you will enjoy. You've been involved in healthcare at home for a long time, and you were mentioning a clinic you were on the board of, and that was your start in home care. You want to talk to me how that actually happened and how that came down?
Well, Marilee, back in 1985, my wife of 5 years and I already had 4 kids, and I really refused to work the hospitals back then because I didn't want to work nights and weekends because our little family was growing so quickly. And a friend of mine said, well, hey, look, I've got this home health opening. Somebody is, a director of nursing is getting ready to leave to have a baby, and she's not coming back. Would you help me out? And he told me what he could pay, and I said, well, I really can't afford to raise my family on that, but I'll bail you out. And the next thing I know is, they also needed patients seen on weekends, so that helped me to kind of make up what I wasn't going to make in the other role that I had been hoping to find. So here I am. That was 1985, and we're talking now in 2018, and I'm still working in home health and still loving that nursing has given me an opportunity to work with people in the home setting, and it's been a rich experience meeting people where they live and crossing that sacred threshold into their home is a very different nursing experience than my colleagues who do such good work in the acute care settings.
Talk to me a little more about that, because the fact that people are at home when they're receiving care does provide a different equation to the wellness equation, doesn't it?
It really does. And, we have been so very focused on the hospital setting for many, many decades. We educate and train physicians and nurses and other healthcare professionals with the primary focus being on that hospital setting, the acute care setting. Working with people in the home setting, in their community, where they live, where they eat, where they sleep, where they breathe, 99.999% of their life is very different. The training and education that I had was excellent at Charity Hospital in New Orleans back in the 1970s, and it engaged people on our turf. And today most healthcare workers are engaging people on the healthcare workers' turf, whether that's a hospital setting, a physician's office, a clinic, etc. But when we walk into that patient's home, there are a number of things that change from what we've been educated and trained to do. Our focus in that acute care setting was more about the diagnosis, about the treatment, about the nuts and bolts that are part of what we all know and love in healthcare. But when you cross the threshold of somebody's home, all of a sudden there are other really critical aspects of our ability to think on our feet and our ability to engage people. For example, just driving into the neighborhood, we know some things about the public health issues that individual has to deal with. We know a little about the neighborhood that they live in. We know when we knock on their door, whether we're walking onto their front porch or wherever, we know a little bit about the socioeconomic situation they're in. When they allow us in the door, we can see pictures on the wall, we can see the furniture, how things are laid out, and it immediately tells us a lot related to that individual's resources that they have. It can very easily tell us a great deal about the culture that is part of the makeup of that individual. So from a nursing perspective, caring for someone in the home setting takes a whole lot more blending of all of these different bits of information as we try to engage that individual, try to build trust. If we can build trust, then we can certainly be a lot more effective as healthcare workers. And since we're meeting them on their turf, that opportunity to build trust, in my opinion, is far greater than it is in other settings.
And is this something, you're now a professor of nursing, so you are teaching other nurses, and I'm assuming you are teaching other nurses about providing health care at home.
Absolutely. It's a real gift having a brand new career at age 60, and the opportunity to start teaching, and particularly something that I'm passionate about, healthcare at home. I'm lead faculty also related to health policy, but just authored a brand new course around community-based care. So we have been for decades in a fee-for-service model, meaning that whatever we do, the more stuff we do to people, whether it's diagnostics or treatment, the more stuff we do, the more we get paid. We're moving to value-based purchasing, and what that means now is that it's really all about outcomes. So from a perspective of economics, the incentives are far better aligned now for us to be doing things that help people with their well-being, with their health. You've heard the adage before, we call it health care, but it's really sick care, because in fee-for-service, you didn't get paid for anything unless you were sick. So now, as we're moving into the home setting, we're not only trying to focus more on well-being, living well with chronic illness, but we're also thinking about quality around end-of-life care. So there's so many different dynamics around care at home and in the community that are really important, and it takes a different mindset compared to the acute care setting that we've been in. And teaching that has really been a gift, but not only am I teaching that and have I been a provider, but we're also consumers of care at home. Our daughter, my wife and I's daughter, youngest is 27, Brooke has Down syndrome, and she's healthy as a horse, great disposition, was just on the runway as a model a week ago. So she's having lots of phenomenal experiences. But it doesn't change the fact that we are consumers, because she's got caregivers through our state's New Opportunities waiver, which is a waiver for people who have exceptionalities. It allows Brooke to live at home and in a community rather than being in an institutional setting. So that's another very important aspect of care at home, is not only the skilled care that we provide in the home health space that I've been working in since 1985, but also home and community-based services that meet the needs of people who are aging or people with exceptionalities like my daughter.
You know the system, and you're intricately involved in the system. From a consumer standpoint, how would someone find out about a program, for instance, that Brooke is taking advantage of?
It depends on that individual's situation. In the event that that person has Medicare, which is through the Social Security system, it is through federal government. In the event that that individual has Medicare, then they would go to the Medicare website and have a look there, and they would learn what the resources are that are available to them. People historically, and I know things are evolving right now, but those over 65 have generally qualified for Medicare. Other people who have some functional or health limitations sometimes qualify for Medicare earlier, but for the most part it's for the elderly. In Brooke's case, and in the case of people like Brooke who have some exceptionality, which is my generous language for what we used to call disability, they would look to their individual state's Medicaid program. And Medicaid varies across the country. Even though there is some federal funding, the Medicaid is managed by each state's healthcare system. And you would go to your state's website. In Louisiana, it's our Louisiana Department of Health, and there are other names for those Medicaid programs in other states across the country. But that's where someone would go to look for that information in their individual state.
When you are teaching home care to nurses, how is that different from teaching a nurse to work in an acute care setting?
Teaching home care means that we need to be looking at a lot of the broader aspects of what that individual's life is like in the community setting. In the hospital setting, in the acute care setting, again, we're far more focused on diagnosis, we're focused on treatment. That individual's condition is generally unstable as a result of their condition, and as a result, we've got to be much more focused on the medical and the clinical piece of it. Teaching folks about care at home and in the community really takes a bit of a different mindset. I had the good fortune of participating in what was then called the Institute of Medicine, the gathering on the future of home health care. And you were part of that, Marilee. And one of the themes that were so critical to me over 2 days, and I know that we've all got our own perspectives, but through my lens, the two major themes that I saw was, number one, the need for us to better blend the clinical and medical with social supports and services. In an acute care setting or hospital, those social supports and services are really not part of the conversation. They need to be more of a part of the conversation upon discharge, but even then, they're very seldom part of it. So social supports and services have to be part of a really focused effort to evaluate that and to make sure that you're identifying gaps around social supports and services for care at home in the community. The second piece, and again, this is from my own lens, and that is the role of the family caregiver. In our own situation, our daughter Brooke, that I mentioned a little bit earlier, even though she's 27 and very high functioning and actually just finishing a university program that's a 4-year program called Life, Learning is for Everyone, her social calendar is busier than ours. But what we've got to do is, as family caregivers, is to make sure that we are focusing on her needs. Today in healthcare, we overlook the family caregiver. And so as I teach people related to care at home and in the community, it's not only teaching them about aspects of chronic illness, aspects of end-of-life care, and the supports that an individual needs, making sure that we're doing the things that we can to prevent them from being readmitted to the hospital. But it's also about being better at connecting with the family, because that family essentially knows the individual better than anyone on the healthcare team. They know what pushes their buttons. They know what their favorite foods and meals are. They know what sort of behaviors they have that are better or worse for their healthcare condition. So engaging the family caregiver is another critical part of what I try to teach people related to community-based care.
As our society is aging and more people are entering an age where they may have care needs, how are you helping us approach educating the referral sources and the acute system for when home care is appropriate and when it's beneficial?
Yeah, that's a very important question, because I think that, again, today we are in value-based purchasing. So what that means is that we need to be a lot more focused on population health management. We really need to be looking at the demographics. We need to be looking at epidemiology. One of the great websites that everybody should go to is County Health Rankings. A friend of mine, Julie Willems Van Dyke, is the person who put that together through a Robert Wood Johnson Foundation grant. It's based at the University of Wisconsin at Madison. And Julie's work looks at the individual county and actually breaks down those important issues around demographics and epidemiology. So as we are looking to what we should be learning in our acute care settings, in our hospital systems, in our managed care organizations, etc., we need to be really intimately familiar with the demographics and epidemiology. But we also need to go beyond that. We need to look at the cultural breakdown within these different populations. For example, I live here in South Louisiana in the heart of Cajun country. We're well known for delicious foods, but also for some of the heart disease that goes along with that. In the New Orleans area, we have a very large part of the population that is Vietnamese. We also are seeing a significant growth in the Hispanic and Latino population in the New Orleans area. So as folks are providing care in that setting, and as hospital systems are engaging those populations in their clinics and in follow-up in the care settings, it's critical that we become more knowledgeable about transcultural aspects of healthcare. That's a piece that, while it certainly is important in the hospital setting, it becomes far more important when you walk across the threshold to that patient and their family's home setting.
And do you see that cross-cultural education being something that is currently being provided to communities, to community health workers?
Very seldom. There are a few places where this is happening, and in the places where it's happening, it really helps to drive a much richer, more diverse conversation around health, around wellness, and for that matter, how folks look at illness. We can be a lot better at that. The theorist who has done the work around transcultural nursing is Madeline Leininger. Dr. Leininger did extraordinary work in helping us to recognize that the cultural piece of it has to be part of our assessment and part of our plan as we're engaging folks. At this point, I don't think that we're doing a very good job at that. And while it's important related to health and well-being, it also is even more so around end of life. I'll just use one example. I led a group of healthcare workers to Dharamsala, India back in the fall of 2014. And there are lots of stories from that experience, but one is visiting a nursing home that was literally in the shadows of the Dalai Lama's temple. Dharamsala is where he's been in exile since the 1950s. Interviewing the two registered nurses in a nursing home, they indicated they had 150 patients there. So I asked about pain control around end of life. I said, I'm sure with 150 people, you've got a lot of deaths. People are dealing with difficulty around pain. So do you use opioids for treatment? And the two of them looked at one another with a real serious look, and they said, oh, yeah. Last year, we had to send off to Delhi twice to get morphine for two patients who were near death and were in a lot of pain. So with 150 patients, they had only used morphine twice. I thought maybe I'd lost something in the translation. So I asked the social worker who had organized our trip, and he said, no, that sounds about right, because we're talking Tibetan Buddhist communities. And in the Tibetan Buddhist community, their view of suffering is very different from ours in the West. They feel like handling suffering well is part of their life journey, their life experience. So not only that, but he also pointed out that their meditation practice in Buddhism is extremely important, and that if they were on opioids, then they would not be able to engage to the extent that they needed to in their practice of meditation. So those two things are just examples from a standpoint of the cultural education that's so very important when we're caring for people in the home setting.
Well, I have one last question for you, and it has to do with your students and people who are coming into to the healthcare delivery system as practitioners. And are you seeing more people being willing to learn about those extra things that they need to learn about in order to provide good health care at home?
Primarily, that's such an important question, particularly in a time when we're having so many challenges around staffing, around healthcare workforce. Our economics around healthcare are very different from what they were when I entered nursing school back in 1976. The pay for those in home health is very different. The level of stability that healthcare has provided folks is very different from it was back then. So I think that what you're asking is a very important question. And, not only who are we attracting to healthcare careers, but what are we doing to really get them engaged and passionate about aspects of care around compassion, around empathy, and around competency. I'm not sure that I have good answers for you there, but the one thing that I try to do in the courses that I teach is to get students to dig in much more deeply around their own personal reflection, to have a better feel for who they are. What is it that brings them to a particular career choice, and giving them the opportunity to reflect on that and discern whether their decision was one that was a good one. Hopefully helps people to find a place that is a space that brings them joy, no matter what career they choose.
Well, I'll tell you, if I were going to have another career change at this point in life, I'd love to be one of your students. I think I could think of nothing more exciting than to sit at your feet and listen to you sprout some of your wisdom in terms of the healthcare delivery system, but healthcare at home specifically.
Well, you're very kind, Marilee, and I think we're both fortunate to share this particular place in our life where we have had the opportunity to work with people in the home setting.
Yes, I would agree. Warren, thank you so very much today for your time and for your insightful conversation. Thank you so much for listening today. And a special thanks to our sponsors and partners, Access, National Association for Home Care and Hospice, and Core Cubed. Find us online at helpchoosehome.com and on social media. And join us, won't you, to spread the word and help choose home when care is needed.